And now it is with great pleasure that I introduce the chair of this event, Mrs. Kenisha Achap.
Thank you, Ranjiva. Good afternoon, ladies and gentlemen, and a special warm welcome to our colleagues from Mona and Cable campuses and our specially invited guests. I am Kenisha Achap, Treasurer of the Pathology Club of UE. I would like to thank you for joining us for our third installment of our Caribbean Pathology and Laboratory Medicine Student Initiative. The Caribbean Pathology and Laboratory Medicine Student Initiative, which we have abbreviated as CPALMSI, is an initiative that has been established by the Pathology Club of UE in collaboration with our advisory board members, Dr. Catherine Morris and Dr. Alfredo Walker. This initiative is supported by the Department of Pathology and Laboratory Medicine of the University of Ottawa and the Eastern Ontario Regional Laboratory Association. The goal of this initiative is to expose Caribbean medical students to various fields within the scope of pathology and laboratory medicine through a series of consultant-led talks and supplemented by resident-led talks. At this time, ladies and gentlemen, I am tasked, yet privileged, to introducing our speaker for this afternoon, our very own advisory board member, Dr. Catherine Morris, who will be sharing her wealth of experience and passion for pathology in a 60-minute overview of cardiovascular pathology. But before we begin, I would like to give you a brief background about Dr. Morris. Dr. Catherine Morris is a pathologist at Port of Spain General Hospital and NexGen Pathology. She obtained her medical degree from St. George's University School of Medicine in 2010. Having completed her internship at Port of Spain General Hospital in June 2011, she completed a combined residency in anatomic and clinical pathology at the University of Tennessee Health Science Center, in June 2017. She then went on to obtain fellowships in forensic pathology and cardiovascular pathology in Virginia, Commonwealth University, and Mayo Clinic, respectively. Having served in many leadership roles over her career, she as chief resident and her participation in several leadership courses, Dr. Morris was appointed an expert witness in the Richmond City Circuit Court and forensic pathologist at the Trinidad and Tobago Forensic Science Center for her skilled and passionate work, and she was awarded the Outstanding Autopsy Craftsmanship Award from the University of Tennessee Health Science Center. Dr. Morris is a member of the American Board of Pathology, Pathology Society of Trinidad and Tobago, where she serves as its Vice President, Society of Cardiovascular Pathology, and the United States of Canadian Academy of Pathology. She continues to have a passion for the development of pathology as seen by her various presentations and publications, especially in the area of forensic and cardiovascular pathology. Without a doubt, Dr. Morris stands humbly and proud as a pioneer in the field of forensic and cardiovascular pathology, and is truly an inspiration to many. We are all honored, pleasured, and privileged for her to be here with us this afternoon. And so, ladies and gentlemen, I ask where you are to welcome Dr. Catherine Morris.
Today we're going to be talking about cardiovascular pathology. I'm a cardiovascular pathologist as well as a forensic pathologist. And cardiovascular is a very small group of pathologists. It's a somewhat, what's the word? I would say undervalued, but it's not a very popular specialty. And the common reason that, is given for this is that pathologists like tumors, and tumors very rarely occur in the heart, so they just kind of ignore it for the most part. However, because of my background in forensic pathology and autopsy medicine, the heart is somewhat of a big deal. And I will say that most of the cardiovascular pathology people have some kind of ties to an autopsy practice generally. And that's why you see that trend. So let's start with the basics. So what is cardiovascular pathology? And if you remember from my previous talk, you have anatomic and clinical pathology. This would fall in the anatomic pathology section. So it's dealing with tissue. And it's a subspecialty that deals with anything to do with the cardiovascular system. So we're talking about the heart and vasculature. So heart, aortas, blood vessels, that's our realm. And it's often combined with pulmonary pathology. And you can see a lot of fellowships called thoracic pathology or cardiothoracic pathology. And that's where you get that cardiovascular pulmonary combo situation. But there are people like myself who are just solely cardiovascular pathologists or solely pulmonary pathologists in the mix too. In general, the kind of specimens we are talking about that we handle would be things like explanted hearts. So the hearts that you take out from someone before you put in a transplant, those would go to us for examination. Because remember, while most of the time they're going in with some kind of clinical diagnosis, typically the pathology is really the gold standard of whatever it is. But the problem is that clinically you can't go in and dissect the heart and just put it back. So until we actually get the explanted heart, you really don't get a full idea of what may be going on. And you're just kind of maybe getting small pieces of information from the physiology you're seeing, which can have a very wide differential, or from like if you get endomyocardial biopsies, which are very small in of themselves and only sample a limited area of the heart, so and imaging. But really and truly, you need the heart itself to try to nail down some of these cardiomyopathies and more long-standing heart diseases outside of things like atherosclerosis. We also obviously will deal with post-mortem hearts, so autopsy hearts that need further examination. Most autopsy hearts will be dealt with by the pathologist or the forensic pathologist who's doing the primary autopsy. So, but you may find in academic institutions where they have like a large cardiovascular practice, they may send hearts more liberally. So they might send, you know, all the hearts that ever had a bypass, any hypertensive that's over a certain weight probably will go for consult. But that's not necessary at a community practice level. At community practice level, you would typically send hearts for like congenital heart disease or sudden death where you can't find anything else and you want a detailed cardiac exam of like the conduction system or looking for other more subtle changes to try to attribute the death to. And then we also deal with intracardiac and intravascular devices. So when they put in an IVC filter, actually sometimes pacemakers, depending on where you are, when they put in devices to collect clots in the atria for people with atrial fibrillation. If they take those out, we're the ones that will examine it. And typically it's not hard in of itself, but it does help to have experience with them because there are a wide range of devices that are used. And you might be thinking, well, it's out, who really cares? Well, two things can happen. One, if it's broken, you need to be able to know that it's broken, even if it's subtle, because that could embolize and end up in somebody's brain. And that has happened. Actually, part of the reason why these are getting taken out and it's sort of fallen out of vogue being inserted anyway, is because we realize when you leave it there, it gets stuck to the vascular wall and can cause problems in the periphery vascular wall, or pieces of it itself can embolize, or it starts to act as a nidus for clots. We've also, and then you'd probably, so like in the center on this picture on your right, you'll see a picture of an IVC filter, one of the different models. And from here, because I've looked at these so much, I can tell that one of these struts is broken, even from just looking at it here. We would submit all this tissue that is attached to it. And again, you might be like, well, it's probably just thrombus, who cares? There have been the odd circumstances, it's very rare, but there have been the odd circumstances where we've picked up cancer in those, and it has occasionally been the first diagnosis, so it was unknown. So we always remove all the soft tissue and submit it even though it's relatively low yield, you don't want to miss something like that, which could seriously impact the patient's life. So then other thing we get a lot of is endomyocardial biopsies. So this is where they would catheterize the patient, go into the right side of the heart, and they will take a little piece of muscle will be from the endocardium out, because obviously you don't want to go all the way through or you pierce the heart. That's not a good idea. So just going to take a little biting muscle. So we'll typically get 2 or 3 pieces of tissue that are about 2 to 3 millimeters big. And these are usually quite important because the clinicians typically will do this in acute settings of illness. So it's usually a patient that's not doing well, or it's a transplant patient for surveillance. So every year or so, a transplant patient will get one of these done to check for rejection. And the idea is we want to catch any early rejection so that they can adjust their medications as quickly as possible, because you don't want to lose a transplant. Once rejection gets past a certain point, there's no bringing it back, and the transplant heart itself will start to fail. So we want to try to catch that as quickly as possible. And the pathologist is key in that, because the grading system is entirely based on the histology. So those you usually want to get and turn around within 24 hours. Also too, if they have somebody who's very, very ill, and they're trying to establish what the underlying cardiomyopathy is, they will also sometimes do an endomyocardial biopsy looking for things like amyloid or storage diseases. Unfortunately, endomyocardial biopsy is very limited because of its sample size, but if it's very florid disease, we can pick it up. And that will allow a clinician to provide appropriate treatment as quickly as possible. So this is one of these situations where we would be on call, and there have been times when, not me personally, but like my seniors and whatnot would get up from their house at 1 o'clock in the morning, go to the lab to read an endomyocardial biopsy. That does happen, particularly in this setting where they're worried about acute rejection, because as I said, transplant hearts don't grow on trees, they're hard to come by. So you want to try to save it as much as possible. So we will get up in the middle of the night to let you know if there's acute rejection, and that you need to, really go at this patient with some immunosuppressives to try to save it. So we also deal with vascular resections. So anytime anybody gets aneurysm done, and they resect parts of the aorta, or if they take out a vessel, like say you have aneurysm in the pancreatic artery or something like that, then you will find that we will get those specimens. And the reason why we get those specimens is because the aneurysm part of it is really the least of our concerns at that point. What we more want to try to give the clinician is why that person had the aneurysm in the first place. Because some of these people are really clandestine vascularities, and the pathology is really the only way to detect that well. You can have some clinical markers, but they're not going to tell you specifically. And you really need the histology to see what's going on and to rule it in. And also sometimes because it could be due to infectious entities, that's why we will always look at these specimens and ensure that whether we can give you something more about what's going on. Then you have stuff like valvular resections. So if you have mitral regurgitation and you need to get a new valve put in place, same thing with the aortic stenosis is a common one, where they will take out the valve and put in either porcine or artificial valve, maybe even a bovine valve. And so we would get the explanted valve, and those valves, so the biologic valves don't last forever. And so if you give it to someone at a young age, or even maybe in their 30s, you probably have to change it in about 10, 15 years or so, because they just degrade gradually over time. And we would examine those as well. The importance of doing that for the native valves is, again, you're trying to see if there's any other reason this person may have had this degraded valve. So things like differentiating between rheumatic heart disease, you really have, if you don't have history, clinically, you're probably not going to be able to tell, but we can still tell based on the pathology when we look at it. It has a very distinctive look. If you have myxomatous mitral valve disease, we can pick that up and specify that that's what the entity is. If you had sequelae of like infectious endocarditis, and also if you have, sometimes you can actually have amyloid, very rarely, but you can pick up amyloid on valves. And previously, this was not considered to be a major thing to look for because there was no treatment. But now there is some experimental treatments for amyloidosis. So now there's a greater effort to pick up these people as quickly as possible to give them a chance. So we'll look at the native hearts and the explanted hearts in particular. We want to know if there's any signs of infection at all, because then obviously that person needs to be on a protracted course of antibiotics, and the surgeon needs to be aware because the new valve he puts in is more likely to fail. So they have to be aware of all those things so they can try to manage it from the front end preventatively instead of waiting for an abscess or something to form and then have to go back in. Because when you go back in, you're not only going to have to take out the valve you're putting, you're going to have to take out some of the aorta around, and it's going to be a mess. Not to mention the patient will be very, very sick. So then the pericardium, when you have restrictive pericarditis, that, you know, sometimes the treatment the clinicians use is just create a window. They literally just take off piece of pericardium to create some space and they send it down. Again, we will look at that to try to figure out what, if there is a underlying entity that we can name, or maybe even an infectious process or some kind of granulomatous disease going on, why this person is having constrictive constrictive pericarditis. Now, most of the time it's idiopathic, but again, you want to pick up those where you can make a difference anyway. I mean, you're taking it out, just, you know, submit it for some histology. It's really not a big extra thing to do. And then the other type of specimens we get obviously is more like standard pathology specimens, which is your neoplasms and your masses. So anything in the heart, around the heart, so in the pericardium, epicardium, intravascular tumors would fall under us, perivascular tumors, that's all within our realm. And they're rare, but they're very specific entities. Cardiac myxoma is the most common one. The vast majority of time, if you do see a tumor in the heart, it's like, I think something like 60 or 70% of the time, it's going to be metastatic. So that's always your first suspicion. And then after that is some primary cardiac tumor in the heart, myxoma being then the most common. And then other things that tend to be pathogenetic syndromes. So it's also good to be able to accurately name those because it may have consequences for the families involved. So that's kind of what we deal with. And on any pictures, you can see I kind of have a smattering of those kind of things. So I already showed you the IVC filter. And then on the left bottom hand, you can see somebody dissecting of heart, a postmortem heart. And I can tell that this is the explanted heart is the top right. And I can tell this is an explant. And this is from an autopsy because the explant has no atria. And that's typically how they come because they use the atria to attach the new heart to. So explanted hearts pretty much will have no atria at all, whereas postmortem hearts will always have the atria attached, or should, if it's done properly. And then on the right middle picture, you can see this is like a valvular specimen. So I think in this case, it was a tricuspid valve that was removed. And so a surgeon removed it because it was too thick, which is, I can tell you from looking from it, no valve should be that opaque. You should be able to see through it. And so already it's looking like it's diseased, might be rheumatic heart disease. It's kind of hard to tell because you don't have any, you don't see any caudate tendon in this picture, but it's very unusual for your tricuspid valve to become thickened. So that's why, you know, more likely to be rheumatic heart disease because that could affect both sides. And then on the bottom right hand, we have an example of what some would consider maybe one of the most common cardiac masses other than myxoma, but it's a little bit of a controversial entity. It's called a papillary fibrillastoma. And they're very pretty because, so on the right, you see it looks different based on the left and the right picture. That's because they are very much like sea anemones. So when we take pictures and we actually have to float them underwater, and then you'll see all the nice fronds come up and they waft and everything. And that's what it does in the heart. It sits there and it wafts around in the blood. And on the left-hand side is when you don't float it. You really can't see the fronds, which is key to making the diagnosis grossly. Now, why I say this could be considered most common, one of the most common cardiac neoplasms is because initially, if you read all cardiovascular pathology textbooks, you'll see some people I don't think many people still think this, that they used to think that PFEs were just big lambles. Lambles is like a reactionary little mass that happens in the heart sometimes, but they look very different. They're not as complex. Lambles maybe might have like 1 or 2 fronds, and they tend to occur along lines where there's some kind of turbulence or contact force. So like closure of valves, where the valve is maybe hitting a septum, you might get 1 or 2. And a few years ago, they did a study on PFEs, and they found that a lot of them actually have KRAS mutations, which suggests they're actually neoplastic. And what's interesting about these is they tend to like to pop up where you've had previous surgery. So if somebody has a myectomy of like around their septum because they have hypertrophic cardiomyopathy, you may find that over time they grow like this carpet of PFEs for reasons we don't quite understand. And for the most part, they don't do much. However, they can embolize, and when they embolize, they go straight up to the brain and they can cause a stroke. So that's why a lot of the time surgeons will go in and resect these. And also why, if I call something a lamble versus a PFE, it has consequences, because a lamble doesn't really reoccur. It's really a reactionary thing, but a PFE can come back, definitely come back. And if you think about it, if it likes surgical sites, when you just cut it off by a surgery, there's a high chance it's just going to grow back again. So they're very funny. They're kind of pretty but interesting little things that happen not infrequently. And on the top left-hand side, I have a picture of one of those endomyocardial biopsies. And, you know, you can see this, well, so this is kind of the stuff we do. You get immunohistochemistry on these. And we also, depending on where your practice is, you might get immunofluorescence as well. Where I trained, we used to do immunofluorescence as well, because there's a slight different sensitivity compared to IHC, and some of the markers that are available as immunofluorescence are not available as IHC. The catch-22 about that is that you can't just take a biopsy and throw in formalin and do IF on it. It has to be something that is planned ahead of time, because it has to be in a special type of fixative that's not formalin. I can't take a formalin fixed tissue and send it for IF. So as a result, if you are at a place where you don't have that fixative, or maybe just don't have IF at all, or the surgeon sent you something improperly packaged, you're going to have to do only IHCs, and there's some markers you just can't do. And so that's what we would look at to assess for rejection. And there's a whole scale that has been studied over the years, so that we can develop groups where we know, well, for this group, you don't really need to do anything. The clinicians don't bother adjusting medication, but once they cross a certain threshold, that's when we start giving them, we know we need to adjust their meds in some way. All right, so then what are some of the duties we have? And this is really just going to be an offshoot of in terms of these specimens. So obviously heart cutting is a big part of it. And a lot of this will be, as said, explants, so postmortem hearts. And, you know, if you're in a community practice, this will largely be a solo duty. If you're in an academic practice, it's probably going to be a huge teaching setting. You'll have residents, you'll have fellows, you'll have, you know, surgical residents will come to see their hearts, and all sorts of manner of people will come to heart cutting. And then you also do, depending again on where you work, sometimes you can have patient and family meetings, which is relatively, I think, a new thing, but there has been a general push throughout the years to try to to encourage more interaction between pathologists and patients, because there's a lot of stuff that patients want to know about their pathology report, particularly as records become more widely available. They're reading the reports and they really want to understand it. And patients really like the experience a lot of times of talking to pathologists, because we can usually offer a different understanding to the clinician. And so where I train at Mayo, one of the things they piloted is that if you had your heart removed for transplant, they would, after the heart was cut, they would call you and ask you if you wanted to come in and see it. And they also would make like a nice little 3D model, not of the whole thing, of like one of the sections of it. And you'd come in and you can get a chance to, like, literally you and your family, not just you could come with whoever you want. And you'd have these families come in and they would be able to hold their own heart in their hand, and we would explain to them, well, this was what was wrong with it, this was the pathology, this is why you were experiencing what you were experiencing. Some pathologists would even bring slides and, you know, pull them up to a double-headed microscope and start going through with them. Well, you know, you see this thing here, and that's because of this. And I've seen people produce short handouts with diagrams. And, you know, it sounds like, well, what's the point? But it really, they really, really value this. And this is when you want to add value to your service. That's one of the things you can do, and patients really like that. Most of the heart transplant patients I've encountered, the whole event of getting to the stage where you need your heart transplanted and waiting for transplant is somewhat of an emotionally traumatic experience, because they really aren't sure if they're going to die, and they're usually very, very sick. And so now they have this new heart. That comes with its own problems, being on immune suppression, things like that. And in a way, sort of seeing the heart and whatnot can sometimes give them closure as to what was actually going on. Some patients will come to meetings and then realize they don't want to touch it, like it's too strange. But it's nice to be able to have the door open for them as an option, and I think it's something they appreciate. And it also helps to educate the public, because we can talk all we want to atherosclerosis. People don't really get it until they see that clogged up artery, and then they're like, oh, that's why my doctor kept telling me that I needed to, you know, look after my cholesterol and exercise and eat better. They don't understand what we're seeing a lot of times, because they don't have a visual of what we're seeing. So it's very good for that. And then teaching is, as I said, one of the things we do a lot. This again will vary on where you work, but I think on any way you work, there's going to be a level of teaching, because typically even your colleagues may not have had the detailed training you have had, so they will depend on you. You know, just in routine autopsy practice, they might, you know, have a question. So you'll spend a lot of time teaching other people about more minutiae that there's no reason they would have encountered it, because it's not focused on in any general pathology training program. As I said, general pathology is heavily focused on cancer. So they just wouldn't have encountered it. So, and then if you're in an academic place, you're going to teach a lot of medical students, residents, fellows. It's all going to come at you. You may or may not have to cover autopsies. More than likely you will. And, but that again is practice dependent. So I would, you know, if there's something you're considering, I would suggest that you have some sort of comfort level with autopsies, because more than likely if a practice brings you on, they'll want you to help cover the autopsy service as well. And as I already mentioned, you have to be on call for endomyocardial biopsies. And we also do frozen sections. That's more rare, but it is a possibility. If they have like an intracardiac neoplasm, they might ask you to do a frozen section. I do know one situation where they did an FNA for intracardiac mass, and they asked the cardiovascular pathologist to be there to do the intraoperative assessment. So those kind of things do happen, but they are very, very rare, and they're usually going to be based more in very academic places, because generally community hospitals are not, you know, trying to cut out masses from people's hearts. It's a very specialized surgical procedure. And that's the other thing you understand about pathology in general. The specimens we get wherever you work is very dependent on what surgeries they can do. So if you find that you're at a place with, you know, a large breast surgery, you know, they have very fervent breast surgeons, you will get a lot of breast. Similarly, but if you don't have anybody doing cardiothoracic surgery, you're not going to get a lot of heart specimens, which is sort of my current situation. So mostly the specimens I get now is almost always going to be post-mortem. So how do you become a cardiovascular pathologist? Now we've talked about what it is, why it's wonderful, and why everybody should do it. Well, how do you get there? Well, firstly, like I said, it's a subspecialty of anatomic pathology. So you have to do the anatomic pathology first, or in the UK, we refer to as histopathology, before you can move on. After that, depending on which country you're in, there are different things. So in the United States, so you do your anatomic pathology residency, or typically it would be your anatomic and clinical, just because that's kind of how the package comes. But there is an option a lot of times in most residency programs. If you want to drop clinical pathology, you can. It cuts out 1 year from the residency, so it goes from 4 years to 3 years. But once you finish that, you can apply for a fellowship. Cardiovascular pathology fellowships are typically 1 to 2 years, one being the more common one. 2 years is sort of unusual. The only one I can think of off the top of my head that does this is Texas. And the second year is almost entirely research. So, which is a good and bad thing. If you are trying to break into that world of academia and whatnot, and you haven't had time to do research, that would be an excellent opportunity to essentially get research done, and they're going to, you know, they'll be able to give you projects and things, and you can just concentrate on publishing. So while you're like, oh, it's like extra 1 to 2 years, as I have learned previously, being on your side where everything was about how quickly can I get out and work, I've come to realize, don't rush it. Take your time. You want to be trained well, and you want to have a good footing of yourself, because all those years you spend in residency and fellowship and everything, even now in medical school, this is when you're building a career, and you don't realize that, but you are currently building your CV. So if you try to rush to the end, typically what will happen is that you will miss out on opportunities. And usually once you get past medical school anyway, you're getting a salary. So it's not as if, you know, it's the medical school situation where you have to pay tuition, you have no income. You're getting an income. Sometimes it pays to just take your time, and you'll be surprised the year just flies past. So now in the US, there are 9 accredited and non-accredited fellowships. I want to say, this was a little hard to figure out for me. I want to say that there's only 1 accredited one, and that the others are non-accredited, which is not unusual for these kind of specialties, because, and it doesn't mean necessarily non-accredited ones are not good. It just means that ACGME, which is the accrediting body for postgraduate education in the United States, hasn't put their stamp on it. But a lot of times these non-accredited facilities, non-accredited institutions may still have a well thought out curriculum and program. You just need to, and they might have some pretty good mentors as well, like some experts in the field. So for instance, one I can think of is the UCLA one is not accredited, but you know, they mentors write textbooks and stuff, and they have a curriculum. It's just they haven't gone through the process of accreditation. And as I said, it's not uncommon for the, what I would say, the less big subspecialties, and that happens in GI pathology and lots of other pathologies, particularly non-boarded specialties. In the UK, there's no formal subspecialty training set up beyond, you know, your basic cytopathology, forensic pathology, histopathology, microbiology, and those kind of things. In Canada, from what I can see, there's no fellowship program either. And I think that's probably the case as well, because most of the Canadians I know came to the States and trained and then went back. Now, a fellowship is not the only way you can become involved with cardiovascular pathology. And I think this is primarily where people do it in the UK. Because you're probably sitting there thinking, well, how does that work if you're in England? So before, fellowships are relatively a new idea. It's really a way to formalize and standardize training. But before that, a lot of times when you finished your initial pathology training, you just kind of picked an area you were interested in. And if you were a hospital that had, you know, a use or had a department for that, or as I said, there's a lot of cardiovascular surgery, and particularly if you had a mentor there, you would just train under them, sort of on the job training, until, you know, you eventually accumulate the same amount of information. So some of these, you'd find older, some of the older authors probably never went through a fellowship at all. They just were mentored for very long periods of time. So you can still do it, but it's a more personal decision. And even amongst, you know, the Cardiovascular Society, quite a number of our members are really either surgical pathologists or forensic pathologists who maybe have had no formal fellowship training, but have taken an interest in these specialties. So they read extra, they follow the literature, and they will go to society meetings to, you know, learn finer points. And that's how they get involved. And that's a valid way of doing that as well. It just lacks, you kind of just lack the structure and the surety of knowing what you're getting to. It's more self-directed. So, so that's kind of how you get there. Now, cardiovascular pathology is not boarded, so there's no board exams to sit after. You just pretty much do your fellowship, you get your certificate, that's good enough. But as I said, you do have to finish your initial pathology training. For the US fellowships, you don't have to pass your anatomic pathology boards before you start. You can delay them. You just need to finish your residency. That's it. But eventually you will have to sit your anatomic pathology boards. There's no way around that. Okay, so as I already told you, cardiovascular pathology is not boarded anywhere. So it's one less exam to worry about. And unless they have an internal exam wherever you go to train, but I've never heard of somebody really taking the time. Actually, wait, I did have a short quiz or something, but it wasn't, you know, if you don't pass this, it was more to see where I was and what areas maybe I hadn't gotten exposure to. It wasn't anything detailed like a board exam. And and I mentioned this before, cardiovascular pathology is typically done with another subspecialty as well. So usually if you're doing this, you would also plan to do an additional year or two of something else. Forensic pathology is probably one of the most common combinations for obvious reasons. Molecular pathology is another very common combination because there's such a huge element of genetic disease within cardiovascular pathology that having molecular pathology becomes a key thing. And then you also have, oh, I'm sorry, I think. So then you also have, just a second. Right, and then pulmonary pathology, as I already mentioned, is a very, very common combination. And even a lot of times when you do cardiovascular pathology fellowships, they may heavily suggest to you that you use your elective time to do some pulmonary and kind of quasi-create a thoracic pathology fellowship program. And a lot of the cardiovascular pathologists may also cross-cover. So where I was at Mayo, all of them except one, all of the 4 except one also covered pulmonary. Cytopathology is not as common, but it does happen. I know of 2 or 3 people who've chosen this particular combination. And surgical pathology, obviously, you know, if you want to do routine community practice or just, you know, academic surgical pathology and you want further training in this particular area to deal with those kinds of surgical specimens, that definitely happens. So just to give you a brief idea of what my training was like. So I did, you know, 4 years APCP. So and I had to do boards, very sad. And then after that, I did 1 year of forensic pathology, boards again, because forensic pathology is boarded. And then I did my 1 year cardiovascular pathology. I'm not going to get into the details of the training for the previous 2 because that's not what this talk is about. And other people, Alfredo's pretty much giving you an extensive background forensic pathology, and you know, and you kind of got a brief overview of AP and CP. So my rotations involve things like spending time actually with clinicians of cardiovascular imaging, learning the basics of cardiac MRI and CT, so that when I read their reports, I would understand what they were trying to say to me, or how sure they were, what the differential diagnoses they were trying to insinuate were. And I also taught medical students and PAs. So we would have, like, they would have their cardiovascular section, which is integrated with all the, it's on system based. So it's the pathology and the pharmacology is all integrated. And we would have these afternoon sessions where we would bring specimens that we had saved throughout the years. Some of them were 3D models or the original specimens sometimes. And we would bring them down to medical students so they could actually see what mitral valve stenosis look like, see a thickened specimen. And actually on this slide, bottom right-hand corner, you can see one of those models. Well, these are both models actually. And on the right-hand side, you can appreciate that the septum is very thick. And the so that's kind of what we would use those 3D models for. It was a way of taking rare specimens and duplicating it so that we could have one in each of these small groups. And it was small enough that medical students could handle it, and I could point out stuff to them one-on-one and answer some of their questions and give them a better understanding of the disease process. So PAs as well, they would have PA conferences, or if you had a new PA, I would primarily be the one that would have to kind of teach them the basics of like heart cutting and dosing and things like that. So as I said, pulmonary pathology usually factors in hugely with cardiovascular pathology. So I did 2 months of pulmonary pathology as well. Neuropathology, that was a personal choice of mine. That was my elective time. I did 2 months of neuropathology just because my forensic pathologist background, typically the two things we send off consult, brains and hearts. So the more I can learn about brains and hearts, I'm all about. Actually, at one point, I still do consider doing a neuropath fellowship, but that's 2 years, and that just wasn't working out timeline-wise. But who knows? Might go back. So then there is time for research. Usually most fellowships will have some kind of dedicated research time because they want to give you the opportunity to go to a meeting and present and things like that. And there will usually be some kind of autopsy rotation. As I said, CV, you sort of have to expect there's going to be a lot of interaction with the autopsy service. That's one of our main routes of getting specimens. And then when I was doing my cardiovascular pathology rotations, which would be like my core rotations, which is the bulk of it, it was something like 8 months of those. Pretty much every morning for the first few months, I would get up and gross all the surgical specimens for about 2 to 3 hours and prep the gross descriptions, everything. And then the pathologist would come down, look over everything again, and switch whatever they wanted to switch. Later on, after about 3 or 4 months, when I kind of got a handle of everything, I didn't have to primarily gross them myself, but then I became a position of the pathologist. I would come down and check what the PA did. And then after that, during that same morning time, you kind of have to coordinate previewing and prepping your cases. So slides are coming out all morning. And when they come out, essentially you have to look at them, you have to draft your report and figure out what you want to do. Some of the cases, because it's very straightforward, you could even go ahead and put in orders for stains if you know that's what you're going to need and you don't already have a stain. You'd also review any immunofluorescence in the morning for any endomyocardial biopsies that will be coming out in the afternoon, because typically the IF is much faster. So those will come out first. And then in the afternoon time, you'd sign out for about 1 to 3 hours with the pathologist. And then, whatever tasks you have coming off of that, stains to order, people to call, that would happen in the afternoon. And then twice a week in the afternoon, you had heart cutting for about 3 to 4 hours. And on those afternoons, you still had to sign out. So there's a lot of time management involved, a lot of being able to manage multiple places at once. So knowing, okay, well, how long am I going to spend sitting and staring at this slide and reading the book if I have to go downstairs and gross, 5 aortic valves? So, and this is a common thing in pathology in general. Time management is a big, big thing if you want to be successful. Even an autopsy, figuring out how you're going to manage everything you have to do as efficiently as possible while still doing it well. And that requires knowing yourself and also having a clear idea of what you have to get done. So always keep that in mind when you're considering pathology as a specialty in general, that this is not a specialty where things kind of come at you. I mean, medicine all around is like that. It's not going to be like medical school where things kind of come at you in an ordered fashion. People and tasks will come at you from all directions at multiple times, and you have to find a way to triage them and get them done. So why does cardiovascular pathology matter? As I said, it's sort of not the favored pathology subspecialty because we don't have a lot of tumors. However, for me, it's important from my point of view, and this is factored in a lot of why I love this specialty, is as much as we're all focused on cancer, the reality is the top 2 reasons people die are all cardiovascular. And if we ever hope to really understand these diseases, we need to be able to look at these specimens. Any day, tissue is always going to be the gold standard. We need physiology as well, but we also need to understand on a structural and cellular level what's going on so that we can manipulate things and develop new interventions. And so that's why it's important. Also, a lot of our diagnoses have long-standing consequences for the patient. If you diagnose a patient with hypertrophic cardiomyopathy, that affects them for the rest of their life. It affects their family because they are more likely to have it and they would have to get genetic testing done. Similarly, if you tell somebody, well, you have, severe atherosclerosis, that's going to be something they're managing for the rest of their life. So, and mitral valve disease, same thing. So it really pays to be sure of what you are telling these people because it will change their life. And you don't want to lead them down the wrong track, and then they start doing things that maybe they don't need to do because maybe you overcalled a normal variant or something like that. And that's the other thing. Normal variants can definitely mask your disease. It's a big issue in cardiovascular pathology, more than I think most people appreciate. And again, coming back to that same issue, if you call something a syndrome and it's not, that has big consequences. So, and recently cardiovascular pathology really kind of came into the forefront a lot with COVID, because if you're keeping up with COVID and what we've been finding about it, one of the main issues and points of interest has been this idea of thrombotic events and myocarditis, and whether patients that do poorly is because they are actually developing myocarditis and thrombotic events, and are they developing these thrombotic events because they have a vasculitis? All these questions, and really the only way to answer these questions is to do autopsies and look at the tissue and make the diagnosis. Now, it sounds all well and good to say, well, just do the autopsy and make the diagnosis, but diagnosing myocarditis in itself is somewhat of a technical thing, because we do know you can have some scattered lymphocytes just hanging out in your myocardium and nothing happens. So if you were to send that to somebody who maybe doesn't understand that, they would definitely overcall myocarditis a lot of the time. And so you will see all these articles that, I just pulled recently, pathologists in pursuit of COVID-19 culprit. That's where they're trying to figure out why these patients are doing poorly, or we also need to be able to study people after their acute infection to understand what effects COVID has on the cardiovascular system long term, because then, clinicians need to be able to plan for these things. And then I already mentioned the issue of viral myocarditis, and also, in the early autopsies, there was a lot of focus on unexpected features of cardiac pathology. And typically, if you really follow these things, you will see, it's not uncommon, you will see a paper published and it will usually be published by maybe somebody who's doing a small autopsy series that doesn't necessarily have a cardiovascular pathology background. And so they may want to call us, make two associations, and then if you keep reading later on, you might see a response letter from somebody with a cardiovascular pathology background saying that that might not necessarily be the case. You may be stretching the assumption a little bit further. I'm not saying this is always the case, but it does happen. And actually, this article here on the right side in the European Heart Journal was a response to a previous article about somebody linking COVID to a type of cardiomyopathy. And then this particular person sort of raised a question that, you know, it might not have anything to do with each other at all. It might just be circumstantial. So if you're interested in cardiovascular pathology, there are a few organizations that you should be aware of. There's the Society of Cardiovascular Pathology, which is a subset of the US and Canadian Academy of Pathology. A little background about USCAP that will help you understand. USCAP is a major organization for most of pathology, particularly in America and Canada. Also, I would say globally as well. The reason why there is not a UK or European branch is there used to be, but then World War II happened and that ceased to exist, and the US one is the one that survived. So it's considered very prestigious. Being able to present at those meetings and do anything at those meetings can be very competitive, and it's considered very prestigious because they won't just let any kind of research or publications in. So they're very selective. And the Society of Cardiovascular Pathology is a sort of a sister organization of them, and so their meeting goes on at the same time as the USCAP meeting. And then you have the Association for European Society of Cardiovascular Pathology, and that's similar to Society of Cardiovascular Pathology, except this is a European arm. And they actually, to an extent, tend to come to our meetings as well. There's a lot of Italians that come to the SVP meetings. And there's also a UK Cardiac Pathology Network. So they don't quite have a society, but they do have a network. And I think they use that primarily if you have a case of sudden cardiac death in a young person and you're looking for somebody to send a heart to, then it gives you a list of names and specialists who can handle the cases. And then on social media, we do have a presence, and if you're interested, I would encourage you to follow some of these people. So my tidbit, one of the things I do to keep myself educated, you know, it's hard when you have all these things going on to, you know, spend time reading every single journal article and every, you know, new edition of a textbook. And what I found very helpful for sort of passive learning and helping me to figure out what's out there and what I need to maybe look into is social media. And Twitter in particular is very big in pathology. There are lots of Twitter accounts by some prominent pathologists, and they actually post pretty regularly, quite a few of them. So from a cardiac standpoint, you have CRI Cardiac, which is the European, it has to do with cardiac disease in the young, and that's primarily based in the UK. Similarly, UK Cardiac Path is associated with them. Melanie Boyes, MD, who was actually one of my attendings and is really into social media, and she posts a lot of things and she will post interesting cases. So it's a really good way to passively learn. I mean, we probably spend way too much time on our phones anyway. Might as well make it useful, and you don't have to, not something you have to search out for. Your, you know, Facebook and Twitter will just feed it to you. So when you're there, probably doing something you shouldn't be doing because you're wasting time, at least you'll be learning. SVP has their own Twitter account. My mentor, Joe Malcheski, has his own Twitter account. Dr. Buja from Texas has his own Twitter account, and he's also the editor of SVP's journal. And then you have CV Pathology, which is another CV-related Twitter account. And SVP actually has a podcast recently, and I have a picture of it there. They only have 2. But again, like, My advice to you guys is the more passive learning you can get, take it. Because you're trying to cram so much into your brain. If it is that you just listen to a podcast while you're in a maxi traveling home, or you have a long commute in traffic, even if you just retain like 10% of it, at least you would know something you didn't know before, as opposed to just sitting there and doing nothing. And that's what a lot of people, when I was training, I was a way we would fit in that extra time to study in busy schedules in a way that wasn't sit down at a desk kind of thing. It allowed us to sort of more passively learn and kind of cover a lot of topics. And science covered multiple times. So those are little things that will help. And so at that point, that's kind of the end of the presentation. Cardiovascular Pathology said I really liked it. I find it's fun. It's not, I would say, very commonplace. Like, you may not necessarily get a lot of specimens, but it's a nice little community. And what I also like about it is it's small enough that you can really know everybody. So this is actually a picture from the Society of Cardiovascular Pathology's 2018 meeting. And you can actually see me on the top left-hand corner there next to my mentor, Dr. Malcheski. But this is pretty much, this picture, and this one picture is pretty much the who's who of cardiovascular pathology. And, it is nice to be in such a small group, because really you don't get lost in the mix, and you can meet people and you can actually ask them things and develop relations with them. And they're always looking for people to be involved with the journal or with the society and get help. So it's a nice small little family of people who just like cardiovascular pathology. So at that point, I'll close off.
To hand you over to our president, Ms. Anne-Marie Minhong.
Good afternoon, everyone, and thank you again for joining us. It is with great honor that I acknowledge Dr. John Vino and thank him for supporting our Caribbean Pathology and Laboratory Medicine Student Initiative. Dr. Vino holds a Bachelor of Science from Acadia University and his Doctor of Medicine degree from Dalhousie Medical School. He completed a residency in anatomical pathology at Queen's University and a fellowship in cardiovascular pathology at Mayo Clinic. Dr. Vino is the Chief of Staff of the Eastern Ontario Regional Laboratory Association, Head of the Department of Pathology and Laboratory Medicine at the University of Ottawa, the Ottawa Hospital, and the Children's Hospital of Eastern Ontario. Additionally, he is the Director of Anatomical Pathology at the Heart Institute and cross-appointed in the Division of Cardiology at the University of Ottawa Heart Institute. Dr. Vino is a cardiovascular pathologist with a strong dedication to education and is a professor at the Faculty of Medicine at the University of Ottawa and a clinical investigator of the Ottawa Hospital Research Institute. He has numerous publications and case studies in cardiovascular pathology, the Annals of Thoracic Surgery Pathology, the European Journal of Cardiothoracic Surgery, and American Heart Association's Circulation, to name just a few. He's a fellow of the Royal College of Physicians and Surgeons and is a past recipient of the University of Ottawa's Excellence in Education Award. He serves as the president of the Society for Cardiovascular Pathology and sits on the Physician Advisory Board of Accreditation of Canada. And it is a great honor I now ask Dr. Vino to come on to say a few words.
Can people hear me?
Yes, we can hear you, Dr. Vino.
Well, that's great. I'm joining on my phone. I couldn't get my computer to work, but I'm glad I joined partway through the presentation. Sorry, Catherine, I was late. I was having some dentistry done, which is much worse than doing cardiac pathology. You and I enjoyed your talk an awful lot. You and I have an incredible career overlap, in that I did anatomic pathology and then I did a couple of years of cardiac pathology at the Mayo Clinic with at least one person, Bill Edwards, and all of the rest of the people that you trained with were just thinking about cardiac pathology still in the cradle when I was doing my fellowship. It still is the most wonderful fellowship. I was interested in autopsy pathology as well and forensic pathology. But I realized that what I really, really loved was the heart. And I continue to do that. Like you, I had to do something else besides that. So I did surgical pathology for many years and did general surgical sign out. And I ran our autopsy service and I did cardiovascular and pediatric type forensic autopsies. For the last years, where I've been chairman of my department, I've done only cardiac pathology, and it's the best, and I enjoy it. One of the questions you got is, what part do you like the most? I like it all. And it's a wonderful combination of tumors as well as non-tumors, and everything that you learn in medical school and in your residency about various diseases, everything from obstetrics to psychiatry to internal medicine, can come back because the heart is so important and blood vessels are so important in our daily functioning. And as you say, it is one of the main causes of mortality and morbidity, suffering in the world, and it keeps changing. So it's an incredibly enriching specialty. And I was looking at the picture that was taken there. As you say, I'm in the middle of it at the back. You're standing next to Joe, and between the two of us, we probably know everyone in that picture. It's a very small group, and you can do fellowships in many places, and the best way to do one is find someone that has a good track record of turning out good cardiac pathologists. So you trained in one of the best places at the Mayo Clinic, and so did I. So I recommend them thoroughly. But there's great places in Boston. Mary Shepherd in the UK is an excellent cardiovascular pathologist, and there's many people in Europe as well that are incredible cardiovascular pathologists. So I'm really pleased to join you on this session, and I know you're going to go through various things other than cardiac pathology. I'm not sure why you'd ever want to, since I could spend, and I know we could spend hours talking about the various diseases, but I really hope you enjoy the rest of the sessions on the different types of pathology. Pathology is a wonderful career choice, and it is always interesting. Every day is different, and you are making a diagnosis that people act on in the chart. Every case of cancer involves a pathologist. All of the blood work involves pathologists, and we're there providing right up front patient care, and we're very important. So congratulations, Dr. Walker and the group. I see you've got over 30 people on, and I think it's wonderful that that all of you are interested in pathology as a career. So best wishes, and thank you very much.
Thank you very much, Dr. Vino, for that. Thank you very much, Catherine, for the sterling presentation. And I just want to thank Dr. Vino for supporting this initiative officially. The Caribbean Pathology and Laboratory Medicine Student Initiative is fully supported by the Department of Pathology and Laboratory Medicine of the Faculty of Medicine of the University of Ottawa, of which Dr. Vino is chair. And personally, he supports all these academic initiatives. And when I approached him for both the department and EARLA to be official supporters of this, there was no hesitation. To all the medical students online, I hope you benefited tremendously, as I did, from Dr. Morris's presentation. And kudos to Ms. Anne-Marie Minghun for another sterling session, as well as Kenisha, who is the chair of today's session. Thank you.
Dr. Walker hasn't mentioned that he now owes me some saltfish fritters and some doubles, if he can get his wife to make them for me.
And Anne-Marie, you see what I told you? I will pay the debt, Dr. Vino, I will.
We'll definitely be more than welcome to have you in Trinidad for the real doubles experience and so forth. I assure you would enjoy our cuisine tremendously.
I would, but Dr. Walker's wife makes real ones, so I'm told. So we don't want to get in trouble.
All right.
Yes, but doubles are bad for the heart. I agree.
Okay. Thank you to Dr. Vinod and Dr. Walker for gracing us with your presence this evening. Thank you, Dr. Morris, for the intriguing presentation. I enjoyed it personally, and I think everyone who's online right now enjoyed it. It actually sparked my interest because I had some interest in cardiovascular pathology, and after your presentation, I am definitely thinking about going into this field in the future. Thank you so much. At this moment, I would like everyone to open a new tab and type in www.menti.com, or you can use the link provided inside of the chat, right? And you could put in the code 8777142. That's 8777142. And I just want to know your thoughts about the presentation. Give me your feedback. We are engaging here. Was it interesting, informative? Was it eye-opening? Was it out of this world? Could you please give me your feedback on this presentation? And I hope everyone is doing that right now. Let me see if I could do that as well. Everyone is getting on to the awesome. I'm seeing it moving, so that's great. I'm seeing interesting. I'm seeing well informative. I'm seeing eye-opening, well presented. Thank you so much. Fascinating, well planned. It's so amazing to hear these feedbacks because we put so much work into making these events for you guys, and it's really, really overwhelming that you guys are interesting in these events that we brought for you. Thank you so much. And now I will pass you over to Kanisha, our treasurer, to do the vote of thanks. Thank you guys again.
Thank you, Anthony, for that feedback on our session. And now we'll have the vote of thanks. So good night once again, everyone. It is with great pleasure that I now present the vote of thanks for this afternoon's proceedings. As Bruce Wilkinson once said, a moment of gratitude makes a difference in your attitude. Firstly, I'd like to thank our feature speaker and advisory board member, Dr. Catherine Morris, who despite her busy schedule, graced us this afternoon with an amazing and enlightening presentation where we all are extremely grateful to learn about cardiovascular pathology. We would like to extend our most profound gratitude to you and Dr. Alfredo Walker for your contribution in pushing the Caribbean Pathology and Laboratory Medicine Student Initiative forward, and we are truly honored and privileged to have you both as part of our board. We appreciate your endless support and thank you for playing a role in supporting us throughout our journey thus far. We would also like to thank you, Dr. Alfredo Walker, for your presence today. Additionally, I would like to say a special thank you to our specially invited guests present here tonight. Dr. John Vino, we express our deepest gratitude to you for supporting our Caribbean Pathology and Laboratory Medicine Student Initiative, and it was an honor to have you join us this afternoon. Last but not least, ladies and gentlemen, I would like to thank you all for accompanying us tonight and making our event a success.
die out too hard.